the number one cause of burnout in physicians is the EHR and all the alerts that people get. Now we'll talk about clinical alerts. The number one cause of burnout in physicians is the EHR and all the alerts that people get. And your work is building more of these alerts, right?
Yes, I'm a big fan of these alerts. The electronic health record is a fairly new tool in our toolbox. Essentially, since the 2010s, we've been digitizing all of our record keeping and documentation. And this has partially been done by Meaningful Use, which is a federal program to get hospitals and health systems to digitize their record system. So we've had EHRs technically since the 80s, but there was very slow adoption of that. And then during the Obama era, they released this Meaningful Use program, which gave federal money to health systems who adopted electronic health records. And so since then, there's been a huge uptick in the amount of health systems that use EHRs. Now I think it's over like 97% of hospitals use electronic health records, and every single health system I've ever worked at uses these. But it's been a very recent change and has completely altered how care is delivered. When I was a resident, I would spend maybe less than 10% of my time face-to-face talking to patients or on rounds with my attending. The rest of the time I spent in a little closet documenting in this electronic health record. So it is a big aspect of how healthcare is delivered right now. From a documentation standpoint, from a medical legal standpoint, as well as all our prescribing is done electronically. And so since all care is delivered through this one central tool, this EHR, it's a great way of improving the quality of care that's delivered with different pop-ups and different alerts and different ways of changing how the note template is displayed based on the results that are entered into it. And so I think there's a lot of cool opportunities to improve quality by addressing these alerts.
Yeah, and we kind of talked about alarm fatigue a little bit earlier with, most of these being like false alarms. So let's call it, 90% of the alarms that go off in a hospital are false alerts. Like it's not a emergency situation, but you still have to take the time and respond to that. And there's sort of this alert fatigue that's a similar phenomenon within the EHR. So I don't know if these surveys have been done, but if you, ask the average physician, how many of these alerts in the EHR are like relevant or important, or like you're glad they're there, like I would guess, they would say maybe like 3/4 of them they're not happy with, and maybe 1/4 of them they find useful. I guess my perspective on this was like, I didn't particularly enjoy the alerts when I was working in a hospital setting. I found them to be, useful as I was, learning. So I was a, nurse practitioner student doing, my clinical rotations, internal medicine physician. And there are these sort of quality metrics that you're trying to hit. So it's a reminder that, hey, like, if you have a diabetic patient, you do your diabetic foot exam. Are they on a statin, XYZ, these things, these standards of care that should be being met. Now, I can see how like clicking through and having all those checkboxes would be annoying to a physician that's been in practice for, let's say, 5 years. It's like, you know this stuff forward and backward, you're in primary care. This patient is never going to take a statin. They've talked about it. They said, no, I'm not going to take a statin. But every 3 months when this patient comes in and they're getting their A1C check, you've still got that alert you have to click out of. So, I guess examples of things that could be, particularly useful are like, hey, this person is like 45 now. Like when a new guideline comes out, colon cancer screening, right? Went from 50 to 45. So if you're in your routine of like everyone who's 50, you're sending that GI referral, getting the colonoscopy, and then there's a change in guidelines like, hey, based on the newest evidence, we need to start doing this at a different time or in a different way. That could be a really good use case for like a clinical alert. It's like, hey, this patient is 47 and they still haven't had a colonoscopy. Like just as to prompt, and this wouldn't even have to go to a physician necessarily. You could have a nurse in the office or a medical assistant that sort of gets the ball rolling on that referral. So I think that's a really good use case. I guess, what are some examples of what you see as the go-between between physicians and the software engineers, where there are use cases where it's like, why is this even in here? And people are very annoyed by those sorts of alerts.
I think a lot of the alerts that direct patient care are frustrating to the physician. So I think that's kind of where my two jobs kind of collide. One, I'm focused on population health and improving kind of the group averages for large populations. And on my other role, I'm a physician trying to provide the best individual care for the one patient in front of me. And so from a population health perspective, these alerts bring a lot of value. That was a great example of the new changing guidelines. You can provide education to the physicians and require them to do continual medical education, CME. But ultimately, the only way that you can ensure that they're staying up to date with the new recommendations is by changing the workflow in the electronic health record. And also to the point where there's so many more medications than there were 30, 40 years ago, and there's so many new diseases that are discovered. And so the workload of a clinician is quite a bit higher. And so kind of taking that burden off the clinician and kind of helping direct their care through the use of the electronic health record can bring a lot of value. Now, on the other side of that, as a clinician, that can be pretty frustrating because there's this art of medicine and it's not so cookie cutter. You can't just apply the same exact recommendation to everybody. And going back to our earlier conversation, a lot of those recommendations are based on population level data. That's mostly directed by the USPSTF, the United States Preventive Task Force, which is an elite organization that looks at meta-analyses to determine recommendations, but those don't always apply to every single individual patient. So if I'm trying to give the best individualized care possible, it could be frustrating if I'm getting a pop-up saying this patient is due for their colonoscopy when they have no family history, they have no risk factors, and I know they really don't want to get this done. It could cause more difficulty in that physician-patient relationship than actual good. And so I think there's a fine balance between those things. And I think that's why it's important to have clinicians also be involved with creating these tools so that you have the end user in mind. For a long time, these tools were built without the end users in mind. They were built by the legal team and the engineers and the business people trying to optimize how care is reimbursed for. And that leaves the main users out of it, the nurses, the physicians, the PAs, everybody like that. So I think it's a fine balance where you have to bring in a multidisciplinary team to address these things and really do good end user testing before deploying them.
Yeah, so it's like that alert that pops up, that can be a distraction. It can also be a reminder. I guess it kind of depends on where you're at in your workflow. Like there can be a scenario where it's like, oh, I'm glad that popped up and reminded me of this because you've got so many things that you're having to address in a traditional health system in a very small amount of time. So I can see the good and I can see the bad. I guess that's one of my downfalls is that I can empathize with almost any situation and like spin it into a positive for that side. But I guess one of the things I remember from my clinical training was the physician I was with. He's like, try to avoid, interruptions, distractions. He's like, that's when people make mistakes is when they're interrupted or they have distractions. And, I found that to be true. Like, you'll lose your train of thought and maybe that's helpful. You get distracted and then, your nurse says, hey, you've got a call for, this prior auth. You've got to, do a peer-to-peer 5 minutes with this other insurance doc. So you leave the room, you come back in, you're wrapping up the visit, and it's like, oh yeah, we need to get this referral for colonoscopy. Maybe that's a really good scenario. And then you could have the pop-up itself being a distraction. So like you're in the middle of your workflow, you're thinking about something you need to do for the patient, and then you have to click through 3 boxes to get this alert to go away. Like, yes, I'll address it later, blah, blah, blah. And then you lose your train of thought. So it can be a good thing and a bad thing.